Did you know that diabetes-induced renal failure is the most common cause of renal failure in North America? This is a startling fact that underscores the importance of understanding diabetic nephropathy, a condition that affects a significant percentage of individuals with diabetes. It's a type of kidney disease that can progress over time, especially in those with uncontrolled diabetes. The prevalence of this condition varies between people with type 1 and type 2 diabetes. Roughly 20 to 40% of individuals with type 1 diabetes will develop progressive nephropathy after 5 to 10 years. In contrast, only 4 to 20% of individuals with type 2 diabetes will experience this progression. These numbers highlight the critical need for awareness and early detection. Indeed, understanding the pathophysiology of diabetic nephropathy is crucial in managing the condition. This understanding can influence how we approach screening, clinical features, treatment, and prevention. So let's dive deeper into this topic. So, what exactly causes diabetic nephropathy? It's a complex process, but let's break it down. The villain of our story is diabetes, which triggers a series of changes in the kidneys, particularly in the capillary basement membrane and the glomerular mesangium. The capillary basement membrane thickens, and the glomerular mesangium, a specialized connective tissue, expands. Both these changes compromise the kidney's ability to filter blood effectively, leading to glomerulosclerosis, a type of kidney damage. When we say glomerulosclerosis, we're talking about the hardening or scarring of the glomeruli, the little filtering units in your kidneys. This is not a good thing. As the glomeruli become scarred, they lose their ability to filter waste and excess fluid from your bloodstream, which can lead to renal insufficiency, or in other words, kidney failure. Now, there are two types of glomerulosclerosis that can occur in diabetic nephropathy: diffuse and nodular. Diffuse glomerulosclerosis involves a general thickening of the glomerular basement membrane, and it's the more common of the two. Nodular intercapillary glomerulosclerosis, on the other hand, is characterized by specific lesions known as Kimmelstiel-Wilson lesions. But what does this all mean? Well, these alterations in the kidneys don't happen overnight. They creep up silently, often unnoticed until it's too late. That's why understanding the pathophysiology of diabetic nephropathy is so crucial. It's about knowing what's happening beneath the surface, recognizing the silent progression of the disease, and taking action before it's too late. This brings us to an important point. Early detection is key, and this is where screening comes into play. What screening tests are used for diabetic nephropathy? Well, there are a couple of key tests that can help identify this condition. The first is the serum creatinine test, a blood test that measures the level of creatinine in your blood. Elevated levels can indicate that your kidneys aren't functioning as they should. Another important screening tool is the urine test for the albumin to creatinine ratio, or ACR. This test is recommended annually for all patients with type 2 diabetes at diagnosis and for postpubertal type 1 diabetes patients with 5 or more years duration of diabetes. Now let's delve into the clinical features of diabetic nephropathy. Initial changes can include microalbuminuria, increased glomerular filtration rate or GFR due to hyperfiltration, and enlarged kidneys. Microalbuminuria is defined as an ACR of more than 2 mg per millimole for men or more than 2.8 for women. Macroalbuminuria, on the other hand, is an ACR of more than 20 for men or more than 28 for women. Over a period of about 15 years, these conditions can progress to cause hypertension, persistent proteinuria, or macroalbuminuria, nephrotic syndrome, and renal failure, and elevated hemoglobin. A1C level is also an independent risk factor for progression to microalbuminuria. But don't worry, there are ways to manage and prevent diabetic nephropathy. So, how do we manage and prevent diabetic nephropathy? This is a question that echoes in the minds of many who are grappling with this condition. The first and foremost step is to maintain tight glycemic control. This involves closely monitoring blood sugar levels and ensuring they are within the recommended range. In tandem with glycemic control, blood pressure control is vital. A target of less than 130/80 millimeters of mercury is recommended. This can be achieved through a combination of lifestyle modifications and medication. Speaking of medication, angiotensin-converting enzyme inhibitors, commonly known as ACIs or angiotensin receptor blockers, ARBs, are often used as first-line treatment. They are beneficial even in the absence of glycemic control, as they reduce the level of albuminuria and the rate of progression of renal disease in both normotensive and hypertensive patients with type 1 or type 2 diabetes. However, in individuals who cannot tolerate both ACEs and ARBs, the use of a non-dihydropyridine calcium channel blocker such as diltiazem can be considered. It's also crucial to limit the use of nephrotoxic drugs and dyes, as they can further damage the kidneys. In severe cases where renal failure occurs, hemodialysis or a renal transplant may be necessary. With proper management, people with diabetic nephropathy can lead fulfilling lives. This is not just a hopeful statement but a reality for many. In conclusion, diabetic nephropathy is a serious condition, but with early detection and proper management, it can be controlled. We've discussed its epidemiology, pathophysiology, clinical features, and treatment strategies. It's important to keep learning, keep questioning. If you found this video valuable, do give it a thumbs up. And don't forget to subscribe to our channel, MedSign Health 360, for more in-depth discussions on crucial medical topics. Your support keeps us going. Thank you for watching. Remember, your health matters. Stay informed, stay healthy.